We are about to get started quickly. We're not going to take too much time. I salute every one of you for joining. And as usual, when we are done, we're going to have the recording available on the YouTube channel as well. So thank you very much for joining. Today, we have a very important topic. We have a very, very, very important topic. And I have one of the very best in the country currently. I'm privileged to call him a brother, a friend, a colleague. He is a specialist obstetrician gynecologist, a senior resident. He is going to help us with the topic ectopic pregnancy. It is a very sensitive topic. Most people don't talk about it, but it's there and it happens. And bleeding in pregnancy, this is something that nobody wishes on themselves. What causes it? How can it be prevented? What are the ways to go about it? What things can we do to prevent it? That's what we are here to learn today. So please kindly help me welcome Dr. Francis Woba to share with us. Senior man, over to you.
So thank you so very much, Albert. Yes, Dr. Albert has been a very, very great inspiration to a lot of us. And I'm really happy that he's doing this to push the cause of women's health globally. And we are very grateful for giving us the forum and the platform to be able to share our views with regards to women's health. So without wasting much time, I would share my screen and then we can jump straight into having our conversation on ectopic pregnancy. Just a bit. So good evening to you all once again. If you can see my slide, kindly just show a thumbs up.
Yeah, your slide is very visible.
Wonderful, wonderful. Okay, so like Dr. Albert rightly pointed out, I am a gynecologist and I have special interest in the health of women. So today we wanted to have a little conversation around ectopic pregnancy, and then we'll have some other discussion around bleeding in pregnancy. So we'll start off with the ectopic pregnancy. Now, I have put together a little PowerPoint presentation so as to make our understanding of the topic very easy. So first and foremost, we'll go through what the definition is. We'll try to look at what a normal pregnancy is, just so that we can appreciate what an ectopic is. And then we'll look at what we'd call the classification or how ectopic pregnancies are grouped. We'll look at how common is ectopic pregnancy. And then we'll look at factors or risk factors, things that would increase your chances or your likelihood of developing ectopic pregnancy. And then we'll also look at if you do get an ectopic pregnancy, how would you know? Or how would the doctors be able to know that this pregnancy is an ectopic? And then what are the options available to you before we move on briefly to bleeding in pregnancy? So generally, pregnancy is the period in which a woman carries a developing fetus in her uterus. And it usually starts from conception until the time the baby is born. So after the woman has ovulated, what we typically call has laid an egg, the egg moves through the tube. And then it meets the sperm of the man. Now, once that happens, there is a process we call fertilization, where the egg and the sperm meet. Once this occurs, the fertilized egg then moves to the uterus, into the uterus. And inside the uterus, it implants normally within the uterus. And that is what normal pregnancy is. Now, this usually takes a bit of about 72 hours thereabout for all this to occur. So this is just a picture to help you understand or to illustrate exactly what we mean when we say, when you lay an egg. So if you can see my cursor, okay, so this is how the normal ovary looks like. So the eggs start to develop. And then at the point where the egg matures, that is the time where you have to ovulate. You lay the egg. So this is the egg. And then that process is what we call the fertilization. And so from this point, and so it occurs in the tube. The process of fertilization occurs inside the tube. Now, once this occurs, the fertilized egg then starts moving. It moves until eventually it comes to implant inside the uterus. That is at this part. Okay, it implants in the uterus. That is what a normal pregnancy should be. Now, during this process, there may be challenges which may not result in a normal pregnancy. And in that case, we call it an ectopic pregnancy. So in the layman's understanding, an ectopic pregnancy is simply any pregnancy where the fertilized egg does not implant inside the normal part of the uterus. I'll take that again. An ectopic pregnancy is any situation where a fertilized egg, any pregnancy where a fertilized egg does not implant within the normal part of the uterus. Now, this can be due to several reasons, which we'll be going over very soon. So once you develop an ectopic pregnancy or an ectopic pregnancy results, it poses a very serious challenge or a hazard to the woman. And if it is not identified early, it can actually result in the woman losing her life. And so therefore, it's important that it is diagnosed promptly and the appropriate intervention given to the woman, or the necessary support that the woman requires is given to her. Now, typically, as I had mentioned earlier, we would typically expect it to implant inside the normal part of the uterus. Now, there are times that it will not implant within the uterus, and that's what we call an ectopic pregnancy. Now, if you look at the uterine cavity, I would show you a picture very soon here. So if a pregnancy implants here in this part, that is when it is considered the normal part of the uterus. The uterus has got 3 different parts. It has 3 different parts. Now, if it implants within the body of the uterus here, then it is a normal pregnancy. Any other part of the uterus is still considered an ectopic. And so the implantation can be either within the tube itself or any other part. And so therefore, we classify ectopic pregnancies into either a tubal pregnancy or a non-tubal pregnancy. So we call it either a tubal pregnancy or a non-tubal pregnancy. The greater majority are usually tubal pregnancies. And that is the ones that will occur here. And I've illustrated or shown the various percentage frequency of these ectopics occurring in these areas. Now, if it occurs in the broader part of the tube, which we usually will call the ampullary part of the tube, that's about 70%. So these ectopic gestations from here all through are what we call tubal ectopics. Tubal ectopics. Then we've got the non-tubal, and these are the ones that occur here in the cervix. the cervix is part of the uterus, but it is not the normal place where the implantation would occur. So if you have a cervical pregnancy, it is an ectopic pregnancy. You can have an ectopic implanting in what to call, let's say, a cesarean scar. And the cesarean scar is usually done at the lower part of the uterus. So if an ectopic or a pregnancy occurs on the scar, it is still considered an ectopic pregnancy. A few occasions, you may have the pregnancy occurring on the ovary. It will occur on the ovary. That is the egg where the eggs are produced. And that also is a form of ectopic pregnancy. Now, there is also a very rare scenario. And this rare scenario is where you can have an ectopic pregnancy. So you have a pregnancy either in the tube, and yet also you have a normal pregnancy inside the uterus. This is a very rare form of ectopic pregnancy, and we call it a heterotropic pregnancy. So in this case, you have both the ectopic pregnancy and then you have a normal pregnancy. In time past, these heterotropic pregnancies used to be very, very scarce. It was difficult to actually find a heterotropic pregnancy. I have a professor who used to jokingly say that you stand a better chance of being struck by lightning twice than seeing a heterotropic pregnancy in your life. I mean, that was to tell you how uncommon it was. But in these days of in vitro fertilizations or IVF treatments, heterotropic pregnancies have increased. So this is just to show an example also of, so this is an ectopic gestation here, and this is a normal pregnancy lying calmly here. We would discuss all this further as we go. So we are trying to talk about ectopic pregnancy. So we want to know how common are ectopic pregnancies generally. So generally, ectopic pregnancies are not so common. It's about 1 to 2% of all total all pregnancies, and we have a lot of pregnancies. So that tells you already that this is not a very common phenomenon. However, there are certain things that would increase or cause the risk of ectopic to rise, and we'll talk about them subsequently. So it's just about 2% of all pregnancies globally. And once you get an ectopic, you have a higher chance of developing a second ectopic. And so these are the chances you have. After the first one, the chances that you get the second one is 15%. And then if you have 2 ectopics, the chance that you get a third is 25%. Okay. Now, most of the figures we have shown you are actually like global figures. That's what happens in the rest of the world. In our own context, we always want to know and study our own population, because you see, things may be different. What is happening in the US and in the UK may not necessarily be what is happening in Ghana, because our foods we eat are different, the water we drink is different. We are exposed to different things in Ghana as compared to those in the UK. So we did our own study in Ghana, and we found that the incidence or the chances of you developing an ectopic within the population in Kumasi was found to be about 10%, which seems to be quite high. Now, this was explained in the study done by some senior and renowned persons, professors in Confanoche, and they found reasons why this was the case. We'll talk about them as well in the subsequent slides. So the reason for the rising incidence, as I mentioned, was the fact that now assisted reproductive technology, or IVF, has become very common, and we'll learn that IVF is one of the major risk factors for developing ectopic. And then also, sexually transmitted infections. It's been found to be very, very common among a lot of our youth these days. And this also has been found to increase the risk of ectopic pregnancies. So once this has ushered us into the next phase of what we are going to talk about, which is the risk factors. Now, when we talk about the risk factors, it's simply saying, what is it that can cause a person to develop or cause a person's chances of developing ectopic pregnancy to be high? Because generally, if we say the chances in the country of developing ectopic is about 2%, or let's say 5%, there are certain individual differences which may increase the chances. We already spoke about one of them, which is the fact that you have had a previous ectopic. Now, one major factor which has already been mentioned is the infections. You remember the study that had been done in Kumasi, okay? So history of pelvic infection. When we talk about pelvic infection, we're talking about what we call PID, pelvic inflammatory disease, and pelvic abscess. These commonly arise when you get a sexually transmitted infection like gonorrhea or syphilis or chlamydia. Now, these infections usually will cause a scarring or scarification of the tube, because the infection spreads up and it causes the tubes to get scarred. And so it may result in the tube being blocked or reducing the diameter of the tube, and can lead to your risk of developing an ectopic gestation. If you have had surgery on your tube before, the chance that you may develop an ectopic pregnancy is high. Now, when we talk about surgery, surgery on the tube, the common surgery that is done on the tube may be the tubal ligation, or chances that you will get pregnant is 1%. The tubes, that increases the risk. Hello? I hope you can hear me.
Yes, please.
Wonderful. So it's not the tying of the tube per se, because tying of the tube generally reduces your risk of even getting pregnant. However, in the event that you get pregnant, which is what we would commonly call if the tying of the tube has failed, so we would call it a failed sterilization, then you can get a tubal pregnancy. In a few instances also, if you have an ectopic, we sometimes, in an effort in trying to save your tube, may try to just repair the tube, take out the ectopic and repair the tube. That also can cause you to develop an ectopic in the next pregnancy. So tubal surgery is a risk factor for developing ectopic pregnancy. We had already spoken about a prior ectopic or a previous ectopic increasing your chances of developing another ectopic. Then there's the use of IUD, or the oral contraceptives. Again, it is similar to what we spoke about with reference to the tubal surgery or the sterilization. If you use an IUD, your chances of getting pregnant is low. However, if the IUD fails, you have a higher risk of developing an ectopic pregnancy. So it is not per se that the IUD is increasing your risk of developing an ectopic pregnancy, because generally the IUD will actually reduce your risk of getting pregnant. However, should you get pregnant, your risk of developing an ectopic is high. And then there are other non-infectious inflammatory conditions. In recent times, endometriosis, as most of you would have realized, has been trending. It's a condition that suddenly has gained some prominence. So if you do have endometriosis, it also increases your risk of developing an ectopic pregnancy. And then, last but not the least, smoking. So typically, smoking releases some what we call substances, which cause some form of inflammation within the tubes, and it damages the ability of the tubes to move the egg along when it gets fertilized. And so if the egg is supposed to use 4 days to travel into the uterus, because the smoking has released those substances that have damaged the, we call it like an escalatory movement, the escalator movement of the tube, it's going to now take about 8 to 10 days, by which time the egg would have implanted in the tube, resulting in an ectopic gestation. So generally, if you have an ectopic, chances are that you may not know. However, in a few instances, there are certain things that may point to the fact that you have an ectopic. So it depends on some factors. One of it is the fact that if the pregnancy, the ectopic pregnancy, is not ruptured, it may be difficult to detect. However, if it is ruptured, it typically presents with what we call a triad. When we say a triad, we're talking of, it means 3 things. 3 things will point to that. The first is the fact that usually there will be pain. And in the greater majority of women, there will be pain. About 95% of them will have pain. Then they would have what we call amenorrhea. That is their menses, absence of menses for at least a minimum of about a month or 2. So they were expecting their menses, it didn't come. Then suddenly they have pain, and then they may have some vaginal bleeding. These 3 things are very, very common and it's common in about 50% of women that will have an ectopic. So once we see this, we suspect an ectopic. So all that we are saying is that there is a high index of suspicion. We suspect that you may have an ectopic. Then we go on and about trying to prove that you have an ectopic, and then we put in the necessary interventions. Okay, so if the patient or you have an ectopic pregnancy and then you develop the pain, for most people, the pain is usually lower abdominal pain, or it may be limited to the left lower abdomen or the right lower abdomen. In a few instances, it may be back pain. And then if they are bleeding, they may have shoulder pain. Now, as I mentioned, the second part of the 3 things we look out for is the vaginal bleeding. The vaginal bleeding may appear in some and may not. And that's why with that one, it is 75%. In some instances, if it is ruptured, then the woman will have internal bleeding. And the bleeding is maybe a lot or mild. However, it will usually present with some symptoms. So the woman may have dizziness, she may have weakness, and she may even go into what we call shock. So these are the things that we look out for if you should present to the hospital. Or if you do have any of these, it is important that you quickly attend to the hospital to have yourself checked up. Now, if you do come to the hospital, the doctor would have a little chat with you and then go on to examine you. Now, when he examines you, he's trying to look at how pale you are. You look at the white of the eyes. Sometimes they're so white You look at the palms, and the palms are so white. She may complain of having palpitations, and all these are suggestive that this person is losing a lot of blood. In a few times, or on a few occasions also, dependent on the amount of blood loss, the abdomen may be distended. Now, once we see all of this, we quickly we do some laboratory investigations and then quickly do a scan to determine or to confirm the suspicions that we have. Fortunately, in current day, scans are very common. And so it is very easy to do a scan to determine that this is an ectopic pregnancy or otherwise. Now, it does not also mean that all of these, if you have any low abdominal pain, it is necessarily an ectopic. Usually the doctor would entertain other conditions as well, in addition to the ectopic. And then we try to find out if it is not an ectopic, could it be something else? But generally, we are having a high index of suspicion while we do these investigations to help find the cause of the abdominal pain and the bleeding that the woman is presenting with. Now, typically, if we discover or we find and confirm that you have an ectopic gestation, as I have mentioned earlier, the scan will tell us if this ectopic is ruptured, it is not ruptured, or it is leaking, commonly what we call is leaking. The management is varied per each type of ectopic. We may have what we call expectant management, which is sometimes we do nothing. It is possible to find an ectopic pregnancy incidentally. And in certain cases, it will resolve by itself. But most of these are monitored closely in the hospital to see the outcome to the fullest. A few occasions also, you may require medical management. It is not all cases of ectopic that you require surgery. In some cases of ectopic, we are able to put you on some medications. Again, this requires a specific criteria. You need to meet a certain criteria. So we try to look, do you have this, do you have that? Then we put you on the medical treatment. And this is done again in the hospital with very close monitoring. Then last is surgical intervention, where if you do not meet the criteria for expectant management, or you do not meet the criteria for a medical management, then you may have to undergo the surgical management. And the surgical management you opt, or we speak with you, we counsel you on the various conditions that you have. We then take you through the, have a surgical intervention for you, and then you can get better. Yes, as I mentioned, all the expectant management as well as the medical management is based on a criteria, and it requires very, very close monitoring in the hospital. Yes, so I'll put an end to our conversation on ectopic, and then I'll briefly talk on bleeding in pregnancy. And then we can, I'll pause and then take some questions from you. So with regards to the bleeding in pregnancy, pregnancy is broadly divided into what we call trimesters. So we have the first trimester, the second trimester, and the third trimester. For us gynecologists, bleeding in pregnancy, we attend the severity of bleeding in pregnancy is determined by the client is. So for women that would be in the early parts of the pregnancy, we would usually say the first 3 to 4 months. So for those, usually most of the bleeding in during this period is as a result of what we call either an abortion or a miscarriage. When we say an abortion, we are not talking about you trying to terminate it. No. Even if it is spontaneous, when we say spontaneous, the pregnancy itself is coming out. It is still termed an abortion. It is not, it's a non-judgmental term for a pregnancy that is not, it's not staying, okay? So in the first trimester, most of the bleedings are as a result of either it's an abortion or what we call an implantation bleeding. So usually when the pregnancy moves into the uterus and is positioning itself inside the uterus, a few occasions there will be some bleeding, and that bleeding is what we call implantation bleeding. So if it's an implantation bleeding, generally there's very little that you can do. In the first trimester as a whole, once you start bleeding, there is very little that can be done. And that is because at this time, the baby, in our opinion, is not well formed. The baby is still undergoing the process of being formed. And so therefore, there are a lot of things that cannot be done to help you. Either in the case of giving you medications and all that. So if that is the case, we would usually recommend that you have some bed rest. So we would speak with you and then try to come up with, find out why the bleeding has occurred. Now, if the bleeding is within the second trimester, in the second trimester, which is usually from 14 weeks to about 28 weeks, within this period, the baby would have been formed. And if you are bleeding, the bleeding may be coming from the mother or the baby, or it may not even be related to any of the two. Then the last part of the bleeding is when you are bleeding after 29 weeks. Now, you would appreciate that in all the 3 scenarios, the baby's development is different. So if you are bleeding in the 3rd trimester, at that point, because the baby is matured, we try to look at or consider whether we should bring the baby out or otherwise. By definition, in our own part of the world, it is only babies in their 3rd trimester that are considered to be viable. Any baby that is within the 1st and 2nd trimester, by the code of or the definition within Ghana, that baby is not considered to be a viable fetus. So typically less than 28 weeks, we call it an abortion. After 28 weeks, then we call it how do you call it? A neonate or a fetus, a live fetus. So that is the terminology that would typically use. So most of the interventions in the 3rd trimester is aimed at saving the baby. We try to strike a balance, but we push more to save the baby. With regards to bleeding in the 1st trimester, as I have mentioned, because it is far from helping the baby, our focus is usually on the mother. Now, in the case of bleeding, the bleeding may be pregnancy related or non-pregnancy related. For those that are pregnancy related, it is what we would commonly call, it may be related to the placenta, the cord, or from the mother's uterus directly. Placental bleedings may be from what we call placental previa or placental abruption. And these refer to, when we talk about previa, it means the placenta has implanted in the lower segments of the uterus. And it's still there after the 28 weeks. I mean, they are a little bit technical to define, as I'm trying to put it in layman's understanding for you to be able to follow. Now, the placenta itself is that whole tissue that allows for gas and nutritious exchange between the mother and the baby. In some cases, it may separate before or in the normal circumstance, it's supposed to separate after the baby is delivered. However, it may separate before the baby is delivered. When that happens, it is called an abruption. In a few occasions also, it may not separate, but it is found in the lower. On some occasions, the bleeding may be from an infection within the cervix of the woman. And that also can cause some danger for both the mother and the baby. And then, last but not the least, is what we would commonly call show or a normal pregnancy bleeding, when the baby has matured enough and is ready to come. So on the general note, when it comes to bleeding in pregnancy at any particular time of pregnancy is a matter of significant concern for us and for the mother. It's a source of distress for the mother, and so must always be taken seriously. Any form of bleeding, the mother must come to the hospital and be attended to. And that is because bleeding is such that it does not matter the quantum of blood that you are losing. It can escalate so quickly and lead to the death of a woman. Generally, if you take all the causes of women dying in pregnancy, about 60 to 80% is as a result of women bleeding. If we take women who bleed, a great majority of them, a woman who die, a great majority of them is from bleeding. And so any form of bleeding in the first trimester, second trimester, or the third trimester is of great concern. And we encourage that women should quickly report and not try to even manage it at home. It's important to come to the hospital, have a conversation with your doctor or your midwife, and let them make the appropriate determination as to what is causing the bleeding. And then we can then put in the necessary intervention dependent on the stage of the pregnancy at which you are, to save first the mother's life and then secondly the baby's life. I'll pause here and I'll take questions from the audience. Thank you so much.
Thank you very much, Dr. Francis Woba, for such an extensive presentation. Great to know more about ectopic pregnancy and, of course, bleeding in pregnancy. The part that caught my ears was the fact that bleeding in general is of interest to every doctor because it can escalate anytime. It can escalate anytime. And it's also good news to know that ectopic pregnancy is there, it exists, but it's about 1% to 2%. And when it happens, you need to seek medical help immediately so the doctors know what to do. And it's also good to try to take out the stigma around the word abortion. Anybody hears abortion, they assume it's judgmental. It means you're doing something evil, something bad. It's a medical term. We appreciate your definition. So at this point, if anybody has any question, please feel free, put in the chat box in the comment section. Dr. Wuba will help us to answer their questions. All right. So anyone at all has any questions, please feel free, put in the chat box. Dr. Wuba will help us to respond to them quickly in the chat box or in the comment section. Dr. Wuba, thank you very much. Okay, I have a question, but I'll let other people ask questions first. So put it in the chat box and let Dr. Wuba help us with the answers. It's always good to hear from the experts themselves. And Dr. Wuba is one of the best in the field, very practical, and he is very experienced in what he's talking about. I like the way he took his time to make sure he lectured us on fully, especially with respect to the ectopic pregnancy. When it came to the cervical part, I'm sure a lot of people has never heard that one. But Dr. Wuba, something came up recently, it may not be directly related, about twin gestation, where a woman can be pregnant with twins, but the fathers are two. Have you heard of, have you seen, how common is that? That's my question. I know it's not related though.
Thank you so much, Albert. Yes. There is a rare medical phenomenon, and this is the true definition of rare, where you stand a better chance of being struck truly by lightning than ever seeing one in your life. Yes. And you know, yes, it's actually possible. Twin gestation where the lady actually had one who was a black man, and then she had carnal knowledge with a white man, and so she got pregnant for the two of them. One of the embryos was black, or one of the fetuses was black, and the other was white. She carried the twin gestation to term, and she delivered. They were twins, but from different fathers. Yes, that phenomenon actually exists. It's not been truly well understood, but as usual, we have theories that have been able to explain why such a thing may have happened. And I think there have been only, if I remember correctly, either 2 reported cases of such that have ever happened. Yes. But truly, right, so yes, it can happen.
Okay, thank you very much. That was just by the way. But related to our topic for today, when it comes to ectopic pregnancy, we know that the tube on that side is taken out. Now, after that, how soon after that the surgery should the woman be concerned about getting pregnant? Or is there any advice you give to such women in terms of fertility wishes? Any special advice you give them?
So, yes, if you have an ectopic pregnancy, commonly the affected tube would be taken out. In a few instances, that is if you undergo the surgery. As I mentioned, if it's medical, then the tube is saved. Now, if we take out the tube, with regards to how soon you can get pregnant, we typically will give you about 6 weeks. And we add a caveat. You can resume sex as long as you are comfortable. If you are a young lady who is not yet married, we advise that you try as much as possible to not get pregnant until you marry.
Right.
I'm sure you understand why that advice must come, because your chance of getting another ectopic is high. And so therefore, do not carry the guilt, that burden on you that probably have had 2 ectopics, because if you have 2 ectopics and you've had 2 surgeries that took out the 2 tubes, what it means is that you can conceive, but only through IVF. It is not that you cannot conceive. You can conceive, but through IVF. So we advise them to hold on or play it slowly, use protection. And then, as much as possible, if they do have any infections, they should take their time and treat the infections properly so as not to increase their risk of developing ectopics.
All right, thank you very much. And as a follow-up, what would you have to tell a man who is in a relationship with a woman who's had a previous ectopy with a previous removal of 1 tube? And the man says, from what he has heard, the experts say that there is a high risk of a second ectopic. So he wants to back out. What would you tell that man?
Okay, so I'll tell him, so first and foremost, you need only 1 tube to be able to conceive. You don't need both. So that woman is as fertile as any other woman we see walking around. And when it comes to the risk of she developing another ectopic, as I mentioned, these are basically statistics. And that risk is, there are ways by which you can reduce the risk, because we can reduce all the other risk. And in any case, that's 15% of developing the second ectopic is out of the general population of all pregnancies in the world. And so therefore, it tells you that the chances are even minimal. And so therefore, it's not a death sentence. You can still live a normal life and bear kids with no worries whatsoever. So the man should take it easy, understand her, and then provide her the support that she needs so as to have a wonderful family.
Great response, of course, coming from an expert, which means it is what has to be said. Thank you very much. If anybody has any questions, we have a few more minutes to go. If you have any question, put it in the chat box or the comment section on YouTube, and Dr. Wilbur will gladly respond to us. If there are no questions, it only means 2 things. Either he's totally confused you all, or he has really explained everything to the full understanding of everyone. And of course, as usual, when we are done, the recording will shortly be made available on the channel for those who could not join us live. Once again, we are very much appreciative of Dr. Francis Wilbur for your time and for giving us all this expert knowledge, of course, free of charge. Of course, even though it is free for us to enjoy, someone pays for it. That is Dr. Francis Wilbur, for his knowledge, his time, and resources. We appreciate you so much, Doc. I don't see any questions, and I don't want us to spend too much time. We want it to be very brief. So I want to say thank you very much for spending time with us. The recording will be available. People will watch. If there are any questions at any time, I will reach out to you for us to respond to them appropriately. Once again, thank you very much for making time to share with us on these very sensitive topics. And I pray that in the future, when we call on you on other topics such as menopause and other ones concerning women's health, you will gladly respond to us. Thank you very much, Dr. Wilbur.
Thank you so very much, Albert. And may God continuously bless you for all the effort that you are putting in to support and promote women's health.
Amen.
In fact, I follow you a lot on YouTube and all the other channels. And I must say you are doing a very, very good job.
Thank you.
Keep on at it, and then God bless you.
Thank you. Thanks to your support and your availability always. All right. So with all that being said, thank you very much, our viewers, for joining us live. Once again, till again I see you. It's been a pleasing pleasure serving you all. Good morning, good afternoon, good evening, depending on where you are reaching us from. Bye-bye.